So as a very brief introduction of myself, my name is Rowan. I use she, they pronouns. I am a subject matter expert and manager here at C4 Innovations, specifically within our Center for Youth Wellbeing team. I have expertise and experience in working as a peer in a myriad of settings, both in providing one-on-one service, group service, and providing crisis services. And today we're going to be really diving into the concept of peer ethics. We're going to talk about what are they, how do they work. We're going to go over boundaries and dual relationships. We're going to very briefly cover the SAMHSA Code of Ethics for Peers, the understanding that every different state has a different code of ethics. And then we're going to dive in on kind of a really specific aspect of ethics, a frequent barrier that comes up, and talk about what perceived credibility and shared reality are. And then throughout this, we're going to do some case study and some breakout work. So as I said in the beginning, this is going to be a really engaging workshop. If you have any questions, please put them in the chat and I'll mute. I will try to make sure that I answer them as quickly as possible. And I think that's everything. So let's do it. So when we talk about peer ethics, or ethics in general, we're thinking of kind of a shared value set for members of a specific shared group. This can be different things, but for our purposes, we're talking about the ethics that come along with doing peer work. Just like we have kind of personal values that guide us in our daily life, our peer ethics guide us in our work. And I want to note that sometimes our peer ethics might differ from the ethics of our employer. They might have more strict ethics, they might be more broad in some ways, and so sometimes that can be something. So, but having a really good grasp on our shared ethics can really help us to navigate any dicey or stressful situations that might come up and make sure that not only are we acting in the best interest of ourselves and our employers, but also of the individuals that we are serving and supporting, and making sure that they are getting the best support possible. So when we talk about peer ethics, what comes to mind for folks? And you can answer tweet or you can put your answer in the chat. Keely says integrity and boundaries, 100%. So biases, liabilities, yeah. Melissa says behavior as a peer. Sarah says gray area. Matt says non-clinical, strengths-based. We've got responsibility, professional boundaries, competency, person-centered. So all of these different things kind of do pop up when we think about peer ethics. When we look at the code of ethics that SAMHSA developed, the kind of following different things popped up. There's going to be a couple that we're going to dive in a lot today, but to go over them briefly, peers are hopeful, open-minded, empathetic, respectful, honest, and direct. They can facilitate change. Peer support is voluntary. It is mutual and reciprocal. They equally share power. It is strengths-based, transparent, and person-driven. So a couple of ones that I want to highlight that we're going to dive in more depth when we talk about perceived credibility is facilitating change, being mutual and reciprocal, strengths-based, and specifically equally sharing power. That's something that we're going to really touch on a lot later. So one of the things that we saw come up in the chat pretty frequently, and it's something that comes up a lot in peer work, is the concept of boundaries. Boundaries exist in every aspect of our lives. They are these limits and guidelines that we set for ourselves in relation to the people around us. It's how we tell people how they can treat us, and how we're going to treat them. So personal boundaries is equally important as peer workers because they keep us safe and protect our peer relationships. Something that I think comes up a lot, particularly when we talk about boundaries, it's kind of this implication that boundary setting means that we anticipate that the person we're setting boundaries with has bad intentions. And that's not really the case. People do what they need to do to get their needs met, and that includes us. And sometimes those needs and those actions just happen to conflict with our personal or professional ethics and boundaries. And that's okay. But making sure that we are clearly communicating any boundaries is a way to prevent us from becoming enmeshed with the person we're supporting, help mitigate vicarious trauma and burnout, which can really impact us in the work that we're doing and make it so we can't stay in the work for very long, and can protect us from any manipulation that might happen or other ethical concerns that may arise in our work. And these might look different depending on the population that you're serving. For example, if you're working with youth, your ethics might be a little bit more stringent and firm than if you're working with adults. It just kind of depends. Any questions before we go further? So when you're doing peer work, what boundaries do you put in place in all of your peer relationships? What are the gold standards, the one that you do with everyone? Sarah says, I don't give out my personal phone number. Taryn says, hours and days I'm available. A work schedule, we can be friendly, but we are not friends. No after hours. No social media shared. Yeah. No connection to personal life outside of peer work. No social media friending, phone number, location given, remote work. It makes a lot of sense, Haley. No gift giving. Yes. Or receiving. So one that I'm surprised that I haven't heard yet is the concept of PARs. The last time we did this training, that was a big one that came up that had a lot of disagreement. And that's kind of one of the things that I want to highlight is that for some peer ethics and boundaries, they're going to exist no matter what. And for some of them, there will be kind of gray areas depending on the work you're doing, the population you're working with, and your employer. Crystal just touched on something in the chat that I want to make sure that we highlight, because sometimes it is kind of cultural to give or receive a gift. So that is something that sometimes you need to be a little bit less firm on. There are also ways to kind of work around that one to make it so you can still keep your ethics and your boundaries, but accept the gift. If you work for an office or with teammates, it can be, I'm accepting this gift for everyone. So we're all going to share it that way. It's not singling you out. No touching is definitely a big one, Adam. So are there any boundaries that are more flexible for you that only exist in some of your peer support relationships? being support and going to an event or meeting with them. Yeah. Going to shared meetings. Limited self-disclosure, we'll share more in LGBTQ groups, 100%. There are some peers whose homes I do not enter, others I'm more comfortable with. Yes, showing up for them, like working with high school students or going to performance or sporting them. Transportation. Yeah, there's, I think, always going to be some boundaries that are more flexible with individual groups. It might be there's a specific peer that you've worked with for a really long time, so you feel comfortable transporting them somewhere. They've worked with your agency for a long time. It's been something that has always been done with them. Or some peers that you feel okay with them attending the same groups as you. Or you feel okay going and supporting them. I think one of the things that is beautiful and stressful about peer support is that we have some flexibility in the way that we exercise our boundaries outside of some really big ones. And that we can be flexible and supportive. So sometimes our boundaries do still get violated and pushed past, even if we're trying really hard, or sometimes in a point of we've had a really stressful week. It's hard to keep those boundaries up perfectly when you have a bunch of other things happening in your life where you're feeling a little burnt out. Some signs that might indicate that you're struggling with some boundaries, you're having a hard time saying no to a client. You feel like you need to be liked by the people that you're supporting. You need and want them to like you and like what you're doing. You enjoy fixing or rescuing them. You feel like you need to keep secrets about your interactions with them from your teammates or your supervisor. You're acting as a close friend or even as a family member, the person you're supporting. You're developing romantic or sexual feelings for them, lending money or doing other financial favors. You're behaving in a verbally abusive way, or they're behaving in a verbally abusive way to you, and you're kind of accepting it, or you're drifting into other roles of this person's recovery support system, sponsor, therapist, etc. So these are kind of the signs that we see. Does anyone else have any other signs that they see when maybe you're struggling with boundaries? Or someone you've worked with is struggling with boundaries? So one that I've noticed in myself, which is I think more of a feeling than a action, is this kind of feeling ashamed. Feeling ashamed of an interaction I had with a peer of like, oh, I didn't do that right. I wasn't firm enough. I wasn't anything enough, but feeling ashamed of kind of the way that I set my boundaries. That's something that I notice with myself. But it's important to be able to kind of identify what are the things that are coming up for you. So boundaries are something that ideally we establish early at the beginning of our relationship with this peer. They are clear and explicit, but expressed in a way that is supportive for that individual and is avoiding miscommunication. Creating healthy boundaries is a really essential skill that takes practice. It's also something that if you're working with youth or children, it's a modeling behavior by working with this young person and showing that have really excellent boundaries, you're teaching them how to develop their own boundaries. If it's something that you're kind of finding that you're struggling with, it's okay to ask for help. It's okay to reach out to a supervisor or a team member or a mentor, and kind of talk through any difficult situations that you're navigating, whether it be with a new person, or with someone that's repeatedly violated your boundaries. And it's totally okay to ask your supervisor to step in a little bit and be more supportive in that work. William, can you explain what you're saying? I'm not sure if you're asking a question or.
No, I was trying to explain. I'm on my phone, so messaging is hard. I have a boundary with youth where we do not listen to music that is explicitly sexual, violent, political, misogynistic. That gives us an opportunity to explore different kinds of media and explore music mostly that are outside of those boundaries. I find that type of media isn't healthy for me, and I don't want to encourage that with youth. I'm not real clear often if parents or caregivers endorse that kind of music, and so for me, those boundaries are important.
Thank you, William. It's totally okay to have kind of boundaries that you need to set in interaction with a peer, whether it be type of music, especially if it's something that is really upsetting for you. It could also be where you meet, if you're meeting in the community. Yeah. Sorry. So can someone give me an example of how you might express a boundary with the peer that you're working with? This can be small, this can be big, whatever comes to mind for you. Yes. Can you give me an example of how you would express a boundary with a peer? It can be a small boundary, it can be a big boundary. I will put it in the chat. Melissa says, tell them gently. Brennan says, thank you for showing your appreciation, but I cannot accept gifts. I am not comfortable with. I would appreciate if you would respect that. Jenna says, making sure we have each other's attention. Be as specific as possible. We have a customer that regularly comes into the office asking for money and other items they see around the office. And we have just to firmly say no each time and advise them that we can assist with hygiene once a month. And if they have a peer, we can assist with other things maybe. When I first meet with someone, I make sure they know that the expectations are from the start. Tends to minimize boundary crossing. Melissa says, asking if they have any boundaries as well. 100%. Ask them if there's anything that they have a boundary around. Are there any topics that they absolutely don't want to talk about? Are there any people that they don't want to talk about? Are they someone that only wants to meet in public spaces? Are they okay meeting one-on-one in a more private space? But yes, you should definitely ask. what boundaries they might have as well. So when we talk about boundary violations, they aren't always super clear. Sometimes they come in a form that it's kind of hard to identify. And we might wonder ourselves if we're overreacting, if we're being dramatic, or if we're kind of misreading a situation. But when it comes down to it, the most important thing here is your safety and your well-being. So it's always better to be overcautious and kind of listen to your instincts. If something is feeling off to you, that's probably an indicator that a boundary has been crossed. Pay attention to how you're feeling about it. What is your inner voice saying? And even if you're not sure, just bring it up in conversation with a supervisor or a teammate, get their perspective on it. Maybe they'll provide you with some support and guidance that might be really meaningful for you. Does anyone have any examples that come to mind of a time that a peer stepped past your boundary and how you handled it? I will write that in the chat as well. Go ahead, Jasmine.
Okay, first, I want to make sure when you're saying peers, we're speaking in the sense of like our colleagues and coworkers, correct? Not like peer clients.
So when we're speaking of peers, we are speaking of peer consumers that we are working with as a peer support specialist.
Okay, sorry. I was just wanted to make sure I wasn't sure if we were speaking about like our colleagues. Okay, so then in that case, an example that comes to mind as far as boundaries, a client saw me, walking from my car, entering the building, and they were asking me for a cigarette. And, while it, seems harmless enough, I just had to politely decline and just, kind of reiterate that, that's not something that I can do or support them with. Yeah, that's all I wanted to share for myself. I find it's often to kind of keep it short and sweet, in opposed to, trying to maybe justify or explain, and just, no can be a whole sentence when it needs to. So thank you.
Yeah, awesome. Thank you, Jasmine. That's a great point. No can be a whole sentence. I think there are some really specific situations in which we might need to give some context, but most of the time, no is all you really need to say. Does anyone else have any examples they want to share?
This is relatively specific to my lifestyle, but I work with a lot of young men, and they frequently ask if they can, join me at the gym in my personal time. So I have to say no to that, not just because that's my time, but also because the kind of training I do involves a lot of physical contact, and that's definitely a no-no.
Yeah, that's a great example, Brenna. Thank you. My computer is moving ahead for me. So AJ says in the chat, there was a peer who overstepped the boundary for what time and under conditions they could call me. They appeared with their doctor Friday morning. They called me to discuss this at 2:30 a.m. The boundary was pre-crisis or crisis calls only after 5 p.m. I reiterated the boundary and invited her to call me and talk about the issue Monday morning during business hours. That's a great way to handle it, AJ. Thank you for sharing that. So another kind of thing that we see come up with boundaries as peer workers is this concept of dual relationships. So dual relationships are when a provider, such as a peer, has more than one role in someone's life. I think frequently we fly to seeing this as being wildly unethical, because the first thing that kind of comes to mind is engaging in romantic relationships. But that isn't always the scenario, and they aren't always bad, and sometimes they're super not avoidable. And it's not super uncommon for peers to encounter folks that they're serving in their community, especially if they live in that community. So does anyone have any situations where you think a peer might find themselves in a dual role?
Yeah, pretty frequently, at least here in Bend, in the recovery community, it's very common to have friends or family members who either are in recovery or trying to get to recovery turn up to be clients at our program.
Yeah.
Current, sorry.
Is Bend a really small community, Brennan?
There's about 100,000 people who live here, which makes the recovery community fairly small.
That is, I think, one of the most common ones, is if you live in a small community, or even a mid-sized community, the recovery community is always smaller than that. And there's bound to be overlap. Thank you. Taryn says, I have been assigned participants who I have known prior to my work as a peer, as an acquaintance or whatnot. Yeah, 100%. Melissa says, I live in a small town and often interact with individuals who are participants, but just have to switch hats. Melissa with Rad versus I'm just Melissa now. Yes. I think when I started work as a peer, I was working in a really small community where I grew up. And my most, I think, frequent problem was that everyone knew me from when I was a kid. So people that I was supporting and working with were either people that knew my mother or people that knew my family, but it was kind of something that was unavoidable if I was going to keep living there. AJ says, this is one of the boundary issues we discussed on a first visit. We discussed how the peer would prefer this to be handled. Is it okay to acknowledge you or prefer not to be acknowledged? So some other situations where peers might find themselves in a dual role is attending a 12-step group where people that are served are also attending. If you live in a really big community and you're okay with switching groups, that's avoidable. If you live in a small community where there is a single 12-step group meeting, it's not really fair to expect you to stop attending. Discovering that a person that you're serving is dating or good friends with a family member. Attending class at a college where the person served is also attending. Being a part of the same faith-based community. If you're living in a rural or small community, everyone knows everything. And it's really hard to get around that. Having the only one mechanic in town who is also in your case study. I mention this because I feel like whenever I do trainings in small communities, this is always the example that comes up. Taryn says, if I am in a support group of participants, I will limit what I share in the group and save more personal stuff for post-render support. That's a really good way to approach this, Taryn. Thank you for sharing that. So in general, when we're thinking about dual relationships, best practice is to inform your supervisor and just be as open and honest about it as possible. So that there aren't any kind of questions that come up after the fact regarding the way that you kind of interact with the situation. If it's possible, your supervisor may choose to move that person to a different peer or may support you in setting boundaries with this person as you navigate the additional role. It's unavoidable. I think a lot of this really depends on the individual situation you're in. So we're going to go into small groups and we're going to talk about these 4 different examples of boundary crossings that might occur in here. Talk through them, discuss them, and answer the following questions. Was a boundary crossed? If yes, is it one that needs to be addressed? And if it does need to be addressed, how should it be addressed? Kylo, can you put folks into groups? So I'm going to stop sharing for a minute and play my favorite game, the copy and paste game. And I will paste these examples in the chat.
From people, and to have, right, their people they provide peer support to not present in that group because it's their own personal recovery after hours kind of meeting. So it would probably just be easiest if Raymond found a different group to attend that didn't have as many people present that he provides peer support to. And same goes for the people receiving services. Maybe they want to share stuff and they don't want to have Raymond present, you know, for that information. So I think the easiest thing is the ball's in his court to be able to go to a different meeting and get that support in another spot.
Yeah, thank you, Matt. And you're right, it does go both ways. Sometimes you don't want your peer support provider hearing the stuff you want to bring up in group. And it'd be great if Raymond had a space where he didn't have to worry about saying something where someone he was supporting might hear it. He wasn't comfortable with them knowing about it. And with COVID came all of these online group options. So if Raymond does live in a really, really small community where the next AA meeting that he has options to go to is like an hour away, Raymond could also consider joining an online meeting if that's something he wants.
I personally got kind of stuck on the last one
Yeah.
because it doesn't clarify whether or not Deborah is a fellow student or the instructor for the class. And whereas if Deborah was a fellow student, it'd be, I feel, somewhat more acceptable. But if she was the instructor, there'd be a power dynamic between her and a former client, which could be a lot more iffy.
That's a great question. I did not specify because no one's ever asked me that before. But I love the assumption that Deborah is the instructor. So Brennan, how would you handle that if Deborah was the instructor in this scenario?
Oh man, my thought process did not get that far. Let's see what I
That's
can come up
okay.
with. Oof. I mean, 5 years is a decent amount of time, and I feel Deborah could if Deborah's the instructor, approach Lisa as a student and ask her if Lisa is comfortable with remaining in her class because of the history of being in the working in the program that Deborah worked at or maybe currently works at. And, you know, if Lisa is not, respect that and support Lisa in finding a different class to attend with an instructor that was not part of the program she attended.
Yeah, I love that. That was perfect, Brennan.
Thank you.
Especially for being put on the spot. Yeah, that's a hard situation to navigate. 5 years is a decent amount of time, but we also have no idea what the context of that peer relationship was like, if it was something that ended in a non-stressful note. So just having a check-in, navigating that. It could also be further complicated if Deborah's no longer working for them, which could make it easier or harder. So I think one of the things that comes up with boundaries and ethics and peer work is that it's complicated. And sometimes we have to navigate these really nuanced relationships, and asking for help, I think, is always the way to make sure that we're doing it in the best supportive option, and just making sure that we're getting extra feedback. So thanks y'all for doing that. Taryn says, I think being in the same class would be fine as long as the peer did not break any HIPAA laws and only acknowledge the relationship that the other person does. 100% Taryn. So let's dive into the credibility aspect of this. So as we kind of talked about earlier, some key parts of our code of ethics that I want to highlight are that peers facilitate change, that peer support is equally shared power with the person that you're supporting, and that it's transparent. So in order to really kind of effectively act in those aspects of our ethical code, we need to make sure that we know about what barriers might make those aspects more challenging. And one of those barriers is the impact of shared reality and perceived credibility. I want y'all to bear with me. The next section of this is a little chunky, and I apologize for that, but I promise that we will get back to more conversation-based stuff really quickly. So briefly, what is credibility? What comes up for folks when we talk about credibility?
Trustworthy.
Trustworthy, yeah.
Competent and reliable.
Competent and reliable, yes, 100%.
Consistent.
Consistent, yes. I love that one. Honesty, yeah. Shared experiences. So why do we think credibility is important?
So you could be effective in your coaching?
Yeah, so you can be an effective coach. What else? Because the peer relationship is based on trust. If something is credible, it's also reliable. Yeah. All of these are so true. So dictionary says that credibility is the quality or power of inspiring belief. So also trustworthy, being seen as reliable. We kind of see the impact of credibility pop up in our lives all day, every day. It comes up in every interaction that we have. It influences how our family, how our friends, strangers perceive us and interact with us. So an important thing to consider is that some of us automatically have less perceived credibility than others. This could be due to a myriad of different factors, ranging from the color of our skin, the sex that was assigned at birth, our gender identity, our gender expression, sexual orientation, the family unit that we come from, our level of systems involvement, our level of education, the language that we speak, and our concept of reality. All of these different things can either make us have less perceived credibility or more perceived credibility. And I want to highlight the word perceived here. Perceived doesn't mean this is whether or not you're actually credible. It means whether people think you're credible just by looking at you and having a basic interaction with you. A lack of perceived credibility can have really deadly consequences for someone. So a video that I would show you if my computer and internet were my friends this morning is this lovely video, not lovely, but a video of a young Black woman talking about how when she receives healthcare, she struggles to find providers to take her seriously when she talks about pain. Something that's coming up there is the fact that providers are seeing her as less credible. So with that video that we didn't get to watch, but it's in our heads How and where do you think perceived credibility could impact our lives? Healthcare is one that we just kind of talked about. What are some other places that it might impact you? Education. Gina, can you tell me more about the education piece?
I think sometimes I feel like this maybe happens in high schools, but certain kids are viewed as more credible for whatever reason. If, you know, they didn't get their homework done, sometimes they're seen as credible and they get that extra, you know, time to make it up. And other kids are not seen as credible and don't get that extra leeway.
Yeah, that's definitely something that probably comes up. Thank you for sharing that. AJ says everywhere. I'm seeing a lot of folks say social media. Can you tell me more about that?
Well, social media, you can pretty much say you are whatever you choose to be, whether you are actually that thing or not. And then speak with confident authority on whatever subject might be related. So I could say I'm a professor of astrophysics and talk about astrophysics at length, even though I am neither a professor of astrophysics nor do I know anything about that subject.
Mhm. Yeah, that is definitely the case. I had not thought about that. Thank you, Brennan. The criminal system, yeah. Financial institutions, yeah. Social groups, workplace, engaging, interacting with law enforcement, 100%. Family setting, appearance of personal interest, professional practice, yeah. So perceived credibility kind of impacts every aspect of our life. Quick story. So when I was 16, I had an interaction with my primary care provider where I talked about how I was experiencing suicidal ideation. I'm not quite sure what I thought was going to come out of that interaction, but it wasn't going to the hospital. I think I thought maybe she prescribed me some medication or a referral to a therapist, but instead she emergency petitioned me and sent me immediately to the hospital. When I got to the hospital, I was pretty upset. One might say hysterical, crying, very distraught, not super focused or paying attention to anything that was going on around me. So when I'm in the ER, the nurse comes and says, I need you to go pee in this cup, do a drug test for us. I didn't really comprehend what she was saying. Went to the bathroom, forgot to pee in the cup in my state of anxiety, and therefore didn't really take the drug test, which convinced all of the providers there immediately that that must mean that I was lying to them and I was on drugs. I, throughout this entire interaction, was consistently saying, I wanted to leave. This wasn't what I wanted. This wouldn't be helpful for me, and that this would make things worse. Everyone was pretty clear on the fact that I was lying and that I needed to be there for at least 72 hours, except for my mother, who was a social worker, and listened to me and heard me say, this isn't going to be beneficial, this is going to harm me, and I think could tell that my credibility was shot, that no one was listening to me because of age, because of my level of panic, and because they perceived me as being untruthful. And so she lended her credibility to me and allowed me to kind of leave that hospital by saying, I believe her, I trust her, I hear what she's saying, I will make sure that she has a connection with this therapist tomorrow. She scheduled an emergency appointment. She lended me her credibility in that moment because I had none. And I think had she not been there, I would have spent at least 72 hours in the hospital, probably longer. And I think I'd be a very different person now had I had to do that. But that's an example of how perceived credibility can really impact someone for a long term, and how we can kind of support them through that. But so we've kind of all identified that that credibility impacts every aspect of our life. It impacts our healthcare. It impacts the way that our employers and our coworkers interact with us. It impacts how our family and friends interact with us, whether it be when we're talking about the emotional or physical pain that we're in, and if it's seen as valid, or if we're asking for help and we're seen as being dramatic, or just we haven't done the work yet, or we're lazy. Credibility impacts all of this. So another aspect that comes up is this concept of shared reality. So in the study done by Bookman, Ho, and Goldberg, they kind of talk about how perceived credibility impacts someone's ability to receive proper medical care. They call this a form of epistemic injustice. But in their study, they, also talk about how if a provider has a shared reality with the person they're supporting, they are more likely to see them as credible and believable and provide them with adequate care. And if they don't see them as having a shared reality, they might be seen as not credible, which can cause really deep distress for someone. And for somatic healthcare issues could result in them being referred out for a behavioral healthcare provider. When we talk about shared reality, what we mean is whether or not someone, through a short interaction and looking at us, thinks that their concept of the world, that your concept of the world is the same as their own. So if a provider was interacting with me, and they were white, young-ish, early 30s, or from a very rural part of a state, they might see and interact with me and think, I have the same shared reality as you, therefore you are credible. But if a white provider was interacting with a young Black person from a city, they might not have the same shared reality, and therefore are automatically viewed as less credible. That is an aspect that's really important to acknowledge that comes up in this a lot. Are there any questions about that before we go further? And yes, Kay, my mom definitely did advocate for me. She's very good at that. So credibility can really impact us and the peers that we work to support by in a couple of different ways. By one, them not being given choices in what type of care they'd like to receive, being denied medication from a new provider, being prescribed medication that you do not want to take. There was a young woman that I supported a couple of years ago who, while she was hospitalized, told her inpatient provider again and again, you cannot prescribe me this. It interacts with the other medication I take with this other somatic health care I take. They didn't listen to her, and they still prescribed it to her and forced her to take it. When she left the hospital, she immediately went to her healthcare provider, and their reaction was, as you expect, to be, why did they give you this? This makes this worse. Why didn't they listen to you? And it's because while in the hospital, her credibility was seen as not valuable. It's not there. So they didn't listen to her and didn't believe her when she talked about this. It can be Also having a lack of options or receiving punitive reactions while in inpatient treatment or in a school setting, having a lack of options when seeking providers, or being forced into treatment options that you do not want to. These are all things that can kind of come up when we're struggling with perceived credibility. So we're going to go again into our small groups. And we're going to answer and discuss the following questions. And I'm going to give you more time to do this. So don't stress about time. Cello, can we make our groups a little bit smaller this time with like 3 or 4 folks per group? So in your group, and I'll put this in the chat for you, talk about a time where you felt like perceived credibility was impacting the way that someone was interacting with you. If you're not comfortable talking about yourself, you can talk about anonymously someone who supported. And how did this experience impact you? How did it make you feel? We're again going to play copy and paste game. Any questions about this prompt before we go into our groups? Oh, can you please this away?
Empathize with the process in which you're confronting, say, homelessness, food insecurities, social determinants, and dismissed as, oh, well, you're a quantitative number, not an individual who deserves qualitative care. So that contrast was very an experience for me.
Thank you for sharing that, Tishna. And I'm sure that doesn't feel great either. Being seen as a number and not being listened to or treated with kind of care and respect.
Brianna and I both talked about some personal experiences we had with providers and how we felt totally discounted and discounted to the point where we weren't even listened to. And how that kind of set us up to start self-advocating for the type of provider that we wanted, kind of screening providers, and knowing how we felt about it. And that kind of helps. I know it helps me when I'm dealing with other professionals and they go, well, we've always done this. Not telling them, oh, you're doing it wrong. Because they're doing the best they can with what they knew, okay, before recovery came into the picture. So it's, I know how it feels to walk through that fire. And that's something that I have in common with the peer. So sometimes things that don't fit into your experience fit into our experience, and it moves people along. And I think that's one of the ways that peer services manage to move people along. I know I had one supervisor. Well, when I first came into peer work, I was the first peer specialist in Wisconsin to begin with. So what I got were the people I got to assist were the people that the case managers were going, have no idea what to do with them anymore. They're yours. And God, I know how that felt, and to sit down with a person and actually find out what's important to them and how, and the one gal, we were making great strides. But all of a sudden I walked into our supervision meeting and she says, I'm pulling you from her today. And I looked at her and I said, you do realize she had a hoarding problem, which was tied to a trauma that she had when she was younger. And she had just had an inspection in her housing to where she wasn't going to get inspected every month anymore or every 6 months anymore. She wasn't going to get inspected until the else in the building did. And I brought that up to my supervisor, and she looked at me and she says, "How much more time do you need with her?" It's I find a lot of times the professionals, because of their ethics, which are loosening up, and I'm glad to see that, don't build relationship. So people don't trust them. That, you know, we know what it's like not to be trusted, and we know what it's like not to be listened to. And we know what it's like for me, I know what it's like for me to tell somebody something and have them go blab it to every other professional I know. You know, as a client. As a peer specialist, I don't do that. I can't do that. My ethics tell me I can't do that. The discussions I have are confidential except in 2 cases, when it's going to hurt them or someone else.
Thank you for sharing all
So,
of this, AJ.
you know,
We
and trying
have
to
move
get
on
that
for time.
across to them is tough.
Thank you for sharing all of this. I do want to make sure that we're moving on for time so we can get to our last breakout group. But you're right. The peer role is so incredibly crucial. And just knowing those experiences and having felt them makes the role so valid. Thank you. So part of our role as peers is to strive to really equally share the power that we have with those that we support. Sometimes that means learning how to use our own credibility and lending it to someone that we're supporting, or supporting them through navigating the situation where they're being perceived as not credible. And there are a couple of different ways to do this. Does anyone have any ideas of how you might support someone through navigating or lend your credibility to them?
I'll chime in. Credibility for me is understanding that self-care is important and checking in with myself. What are my levels of tolerance? What am I ready to hold space for? And because compassion fatigue, in contrast with integrative care, understanding how the doctor's workflow is completely different. It's like touch and go. They're assessing what's needed and prescribing or diagnosing, as opposed to peer support specialist having the level of care to be able to meet the individual with their readiness level, knowing what your readiness level is and how that can develop a mutual plan of action for, I love the word heuristics, because it's not necessarily teaching or guiding, it's more so allowing them to just get to know themselves again, post-traumatic event or post-traumatic information shared, or, whatever the recovery or resiliency is being implemented at that time. So just checking in with self, knowing what your tolerance levels are, and making sure that you're not bringing, the previous conversation you may have had, which made you feel upset, into the new correspondence that you're seeking to support another peer member.
Thank you, Tishna, for sharing that. We've also got Jasmine in the chat saying, sharing our own lived experience when appropriate to encourage the clients we serve and work with. Yes. So a couple of different options of ways to help and use your own credibility. Teaming up. Find good colleagues or supporters that you know see your value and voice. Those clinicians and providers that you know see the value of the peer role and will listen and uplift your voice. And ask them to help uplift what you or the person that you're supporting might be saying. You heard me talk earlier about my mother when I was in the hospital and how she was lending her own credibility to help with mine. She was echoing my choices and allowing the doctors to see them as valid. You can also lend your credibility to the people that you're supporting. Use your peer skills to find and develop common ground. Help someone see the shared experiences and commonality with the person they might not be recognizing, so they're able to more view them as credible. And I think the last one, anti-stigma work tells us that education and awareness building work. So try that one. So we're going to go into our last breakout groups. Cello, we can go back up to I think 5 people per group. So in these breakout groups, AJ says, I must realize I am not all knowing, realizing each person must find their own path to recovery, knowing and understanding their options, even though it might not work for me. 100% AJ, thank you. So in our small breakout groups, you're going to be given a case study. You're going to work together to identify where perceived credibility may be impacting someone and how you as the peer supporter could help. Back everyone. So before we end today, I want to do a quick debrief. In your case studies, what steps did you take to support your peer? And were there any barriers that came up that you were really not sure about how to navigate around?
Are you going by like groups, the first group, second, or just?
I'm gonna let folks participate as they want. So feel free to dive in.
Taryn or Sarah, y'all want to go for it?
As my son's on my screen, I could barely see where the unmute button was. So for case study 1, we kind of just said that with her not wanting to do like any services for herself that are clinical at the time and everything like that, that we just kind of think that we should like I can't say the word emphasize or whatever it is, with her and just like validate her feelings about the situation. We would want to maybe like collaborate with the friend that she has to maybe educate her a little bit more on the healthcare system. And then just maybe like, recommend some non-clinical sources, like maybe like a community group that she could be a part of or something like that. And then just like normalizing self-care, to make sure that, she's at least doing something to take care of herself at home. And then maybe like exploring like what the issues are with her daughter, whether they're like academic, behavioral, whatever, and then seeing what resources we can help her with for that too.
So thank you. Does anyone else from that group want to add anything?
Good job, Taryn.
Who wants to go next? Did anyone work on number 2, Jane?
I'd prefer that someone else from the group would speak, but if no one else will, I will.
I can, we kind of like came to the conclusion that her physical ailments had to be addressed instead of rerouting.
Were there any kind of specific ways that you thought you could support her in addressing those physical ailments? Were there barriers that popped up?
Mainly asking questions.
Asking questions to Jane or to the providers?
To Jane.
Thank you, Melissa.
There were so many other things that could have fed into this scenario, the psychosis, the addiction. She's in a like treatment program, which tells me that she's probably stopped using, which could affect the psychosis, and the psychosis is rooted in trauma. What happened before she got the stomach ache? Is this a trauma reaction or is this an actual physical reaction? You know, so there's so many other things. So finding out from the doctor once I get there, what has he, you know, what Jane, what's the doctor asked you? What's the doctor done? And then asking Jane specific questions. But while all this discussion is going on, CAT scans can be done, blood work can be done, you know, and to more reassure her that at least her stomach ache is being addressed, you know, in the situation. And just reassuring her that it's going to take time, you know, but before they can give her any more pain medication, number one, they have to find out what's wrong, because if she needs surgery, they can't give her pain medication. And number two, what type of pain medication did she take before she came? Did she take aspirin? You know, what did she take? Is this nerve pain or is this actual skeletal muscular pain? There's different types of pain medication, you know, so just asking a lot of questions and trying to determine some answers to reassure her.
Thank you, AJ. I do want to point out one thing with Jane is that Jane uses they, them pronouns. So we want to make sure that when we're supporting Jane, that we're being mindful of what pronouns they use. Did anyone else have one that they wanted to discuss before we wrap up?
Oh, one other thing that I wanted to bring up is that first thing I would want to know was what was her blood pressure when she came in.
As a reminder, Jane uses they, them pronouns. So what blood pressure did they have?
Because if she's in pain, her blood pressure is going to be high.
Thank you, AJ. So thank y'all for being here with me today. These are my references. There's a lot. Are there any questions that you all have before we wrap up?
Thank you for a great class, Rowan.
Is there a
Thank
survey
you.
to be put in the chat?
There is not a survey to be put in the chat, but thank you for checking with me. Thank you all so much for joining us today and for engaging and being present. And I hope that you have a great rest of your day and a great start of your summer. And my email is on the slide if you have any questions that you want to email me about later.
Thanks.